Dr. Mahmoud Achira is a clinical doctor completing his internal medicine residency training in the UK for particular interest in lung oncology and respiratory medicine. Alongside his clinical training, they're an academic clinical fellow undertaking research training with the National Institute for Health and Care Research at the University of Lincoln, where he's completing his MSc research. Throughout his clinical education and postgraduate training, he has been actively involved in both qualitative and quantitative research, with work published in peer-reviewed journals and other presented at different international conferences. Currently, they're collaborating with Lincoln Institute for Rural and Coastal Health, where the research is studying the impact of socioeconomic deprivation and isolation on lung cancer care, aiming to contribute to service development and improvements that reduce disparities in cancer care. So we have a wonderful presentation planned for you, a great speaker of high caliber. And so I invite Dr. Asher on to do this presentation.
Yeah, hello everyone. Thanks for the opportunity. I'm Dr. Mahmoud Achira. I will present our study on the influence of geographic isolation and deprivation on lung cancer care experiences in coastal, rural, and urban areas, which is done in Lincoln Institute for Rural and Coastal Health in the University of Lincoln. As background, we all know that worldwide lung cancer remains one of the most commonly diagnosed cancer and the leading causes of cancer-related mortality. As we can see in this chart, statistics done by the American Cancer Association in 2022, when both sexes were combined, lung cancer took the lead among incidence as well as the mortality. We also know from evidence-based and from studies that poorer cancer outcomes, including lung cancer, are associated with socioeconomic deprivation. And the UK is no exception here. But what we didn't much know about, which is the reason of our study, the reason why we conducted the study, is what are the exact challenges that are faced by the patients who are residing in deprived areas, and whether there are differences among these challenges in different deprivation settings. For example, in this figure, a statistics done by Cancer Research UK from 2015 to 2019, you can see here the 6 months survivalship in lung cancer increases as the deprivation decreases when we compare the most deprived to the least deprived areas. So when it comes to the methodology, this is a qualitative study, which is done by a secondary analysis of patients' data collected by semi-structured interviews. And this analysis was done by interpretative phenomenological analysis, which is a useful qualitative analysis method which generate main themes representing the results. And it's known for 3 main characters: the ability to analyze the data using geographic depth, prioritizing individual meaning making, which means it does not just describe what happens, but it gives us a window to interpret the patient's experience and add meaning to it. And the third one is the capacity to eliminate how social structure contexts. So this study was done in Lincolnshire. Lincolnshire is the 2nd largest county in the UK after Yorkshire. And as you can see here, this is the location or the map of Lincolnshire area in England. These 2 maps for Lincolnshire area, the first one represents the distribution of the different settings. So you can see the coastal areas in orange. Then you can see the rural areas in green and yellow, and the urban areas in orange as well. The second map, which represents the distribution or index of deprivation. So the most deprived areas, as you can see, are amongst the coastal areas, the darker color, with some actually high deprived areas within the rural pockets of deprived areas within the rural or urban areas. When it comes to the sample, 16 patients, we took 16 patients, 6 from coastal areas, 6 from urban areas, and 4 from rural areas, or resided in the most deprived quintiles. The results. So 5 main themes or results were generated: boundaries or difficulties faced by the patients. Some of these difficulties are common amongst patients from deprived and non-deprived areas, but some of them are unique to the patients who live in deprived areas. So the first one is the healthcare access barriers, which includes the long distance travel the patient makes to their appointment, to their treatment, the unreliable and infrequent transportation, the parking difficulties. The second one was the lack of structured support. Patients commonly agreed that there is lack of streamlined information about their cancer pathway, and there is a lack of awareness of the financial entitlement. And also, we found that patients who had previous cancer experience are more familiar with their cancer pathway better than the information given to them. The third results was the delayed diagnosis and fragmented communications between healthcare professionals and patients. The fourth results was the psychological, physical, and financial impacts, which actually comes from all the previous results. These results or these difficulties can add an emotional burden, psychological, financial burden on top of the cancer burden itself. The fifth results is on the positive side of the results, which we found that patients who had family and friend supports, or those who had formal supports from cancer organizations like Macmillan Cancer Organizations, had an easier cancer journey. Now, it's worth mentioning that most of these results are more profound in patients from coastal and rural areas comparing to the urban areas. So to sum up, this is a qualitative IBA study highlights the challenges faced by lung cancer patients and caregivers in isolated deprived areas. Those in rural and coastal areas in particular faced additional burdens of travel, transport, financial constraints. While the network offered some relief, but there should be targeted interventions and policy change to ensure equitable patient-centered care. 3 possible interventions we can suggest: to design comprehensive guidance for the patients to make them more familiar with their cancer pathway and to what expect from their cancer pathway. Second is to improve the healthcare accessibility services and treatment centers, so we reach out to the patients as they reach out to us. The third one is the crucial need to improve the infrastructure and transportation. These are the references, and thank you. There is any question?
Wonderful. Right. So thank you very much, Dr. Achira, for that great presentation. I'll ask a question because I think our AV person is not there right now. So in your work, I understand this is qualitative and it's very, very informative. I really appreciated that. I'm seeing similarities with the previous presentations, especially the one from Vanuatu. Did you notice in your interviews any evidence from social disparities within this rural community that you studied? Is it evident for you that there is someone who, I don't know, was low education would have had more difficulty, or is it would you say it's similar, identical?
Well, in order to answer your questions accurately, I have here my colleague, Dr. Samuel Cook, who can provide you with a better answer about this.
Yeah, sure, no problem. So just to give a bit of a context, myself and my colleague behind me, David, were involved in the initial study in which the secondary analysis came from. And so to answer your question in terms of, could you just repeat that in terms of, did you say education?
I was more just wondering, because in the Caribbean, we know we're very much disadvantaged compared to other places, North America. And so I understand this is a more rural coastal context in the UK. Within that rural zone, are we seeing disparities, even the persons who live in that zone?
Yeah, no, that's a really good question, actually. So obviously we work at a kind of rural and coastal health institute, and I guess what we always say is that no two rural places are the same. So certainly, yes, there are going to be differences across different rural areas in terms of, what we highlighted there in terms of access, kind of information, signposting, etc. In terms of Lincolnshire, it's what we kind of tend to see is that. So I guess, across Lincolnshire is some of the challenges are quite similar. The system's quite fragmented. The transportation is really poor. And that's also kind of, that also spills over to the coast as well, in which we do see urban areas, but it's largely kind of, I guess, seen as kind of rural, kind of coastal areas. And especially if we compare that to kind of like, the urban side of things, where there is kind of more centralised care and the centralised kind of systems in terms of transport, there's kind of, better kind of communication and information sort of thing. So, I guess in terms of that kind of rural space, no, we don't see much difference between kind of, different places dotted around, but collectively, I think, a lot of these rural places do experience the same problem, especially when we're kind of looking at those that are in the, most deprived kind of deciles.
Okay, I appreciate that answer, and I appreciate you contributing to this conversation. I think I've learned quite a bit. I don't know now that our AV team is back in the room. I don't know if we have any. Just look at the chat really quickly, or if I can do it. I don't know. Okay, so I think okay. Right, so I'm not seeing anything else in the Q&A. Of course, I don't want to end it here, but we have to. I'm more than happy to discuss with you, Dr. Achira, and your team, if you want to continue this conversation. But I really appreciate you guys making this submission to this conference. Thank you very much.
Thank you.